All right, guys, now let's move on to the hematology section, starting on page 342. Before we start talking about hematology, let me explain to you guys what is high yield about hematology. And the thing that's high yield about hematology is very softball, classic presentation stuff. So a lot of medical students freak out about hematology because they don't know enough about leukemias or lymphomas. It's not the complicated stuff that's difficult with hematology. It's the softball stuff that's difficult. You just need to make sure that you know, all right? So don't get freaked out about hematology. This is why we save hematology for the very last day of the class, because it's just a brief review, and it's very simple stuff. It's knowing the drugs, knowing some of the clotting factors, not all of the clotting factors. You don't need to memorize the coagulation cascade. And so it's pretty basic stuff, right? Softballs, not fastballs, not curveballs, just softballs with hematology. So having said that, let's move forward with hematology on page 342 with blood cell differentiation. This is not something that you need to memorize. This is not a marker board topic. It's just just a fundamental exercise to help you understand where things are coming from. So this is more of a completeness sort of diagram so that you can have this fundamental understanding. In the margin there, just clinically, it might be important to know that white blood cell differential from highest to lowest, of all your white blood cells, you have the most neutrophils, and then you have the most lymphocytes, and then everything else is in short supply, your monocytes, eosinophils, and basophils. We've talked about what can cause eosinophilia. Well, let's move on. Let's talk about erythrocytes next. So erythrocytes, they're anucleate. There's no nucleus in erythrocytes. They're biconcave. And so with the biconcavity, they're also very flexible. So what is the molecule that provides the biconcavity and the flexibility of your erythrocytes? Well, one of them is spectrin. So this is a molecule you need to be familiar with. Spectrin is responsible for the biconcavity and flexibility of erythrocytes because they have to go through narrow capillaries and they have to be able to meld to the capillary shape and then make it through that capillary. So anytime you don't have that classic biconcave shape, like with sickle cell or like with hereditary spherocytosis, you're going to have excess viscosity. You're going to have sludging in the capillaries because red blood cells are not designed to have that shape. They're designed to have this biconcave shape. It also says that the source of energy for red blood cells, erythrocytes, is glucose. And we mentioned this in the biochemistry section, that in the fasting state, your erythrocytes still need glucose. 90% of that is anaerobically degraded to lactate and 10% by the H&P shunt. And so if you have a deficiency of something like pyruvate kinase and you cannot go through glycolysis, then you're going to have a problem oxygenate or giving energy to your red blood cells, and they're going to have lysis for that reason. We'll mention that again a little bit later. Those terms in the margin, definitely important to know that erythrocytosis is the same thing as polycythemia, all right? So polycythemia is classically what we talk about in the clinical setting, but it's also referred to as erythrocytosis. It's an increase in number of red blood cells. Anisocytosis is varying sizes. Poikilocytosis, varying shapes. Reticulocytes are immature red blood cells. So when you have your bone marrow churning out, being very aggressive about making new blood cells, there's going to be more reticulocytes causing a reticulocytosis. So what causes erythrocytosis? What causes polycythemia? We've talked about a lot of different things throughout the course that can cause polycythemia. Let's just recap some of those things. We mentioned erythropoietin. So excess erythropoietin, of course, can cause polycythemia. When would you have excess erythropoietin? With renal cell carcinoma, with hepatocellular carcinoma, with pheochromocytoma, and hemangioblastoma. All right. We've also mentioned that with chronic hypoxia, you're going to elevate your erythropoietin production to make more red blood cells. And so when would you have chronic hypoxia? When you have pulmonary disease like COPD or obstructive sleep apnea or at high altitude, you're going to make more red blood cells for that reason. We've mentioned that at birth, 65% of Down syndrome babies have polycythemia, so that might be something worth knowing. And there's also a disorder called polycythemia vera, where you have excess number of red blood cells, not because of excess erythropoietin. So erythropoietin is normal, but you still have excess red blood cells. That's polycythemia vera, one of your myeloproliferative disorders, which we're going to talk about a little bit later. So the next section is platelets. With the anatomy, the hematologic anatomy, it's really basic stuff. There's just a few points I'm going to mention with each of these cell types. So with platelets, where do platelets come from? They come from megakaryocytes. So that might be something worth knowing. And the half-life of platelets is in the bottom of the section. It says a half-life or the lifespan is 8 to 10 days. So that might be worth knowing. If you're going to transfuse platelets, those platelets are going to stick around for 8 to 10 days. and approximately a third of the platelet pool is stored in the spleen. So we're going to see later with diseases like where you have antibodies against platelets. If you take out the spleen, that's going to allow more platelets to be in the circulation because you're not sequestering them in the spleen. Leukocytes, again, lots of different leukocytes. There's granulocytes, mononuclear cells. We talked about from the relative number. There's more neutrophils and lymphocytes than the other ones. And we also talked about extravasation of lymphocytes and how you use selectins and integrins to do that. So if you don't remember that, go back to the pathology section of first aid and review that real quick. On page 343, basophils, I don't have anything to add there. They're found in the blood. Mast cells are basically a basophil equivalent, but the mast cells are found in the tissue. And definitely know in the margin that it's involved in type 1 hypersensitivity reactions. And we also talked about how cromolyn is an anti-asthma and anti-allergy drug, prevents mast cell degranulation, and so it can be inhaled for asthma patients, can be used intranasally for asthmatic or for allergy patients. And the problem with cromolyn has to be used several times a day, right? So 3 or 4 times a day. Eosinophils is the next section. So in the margin, it says causes of eosinophilia. So we've mentioned the different causes, and I amended the mnemonic to what you see on this slide here. DNAACP to help you remember these drugs, neoplasm, and then your atopic diseases, allergy, asthma, and then Churg-Strauss with that. Addison's disease, which is primary adrenal insufficiency. AIN, acute interstitial nephritis, we talked about in the renal section, collagen vascular diseases, and parasites like Ascaris lumbricoides, which causes Loeffler's eosinophilic pneumonitis. So for the purposes of step 1, that's your differential for eosinophilia, and it's a decent mnemonic to know clinically. Moving on, neutrophils, we've seen that, we talked about how skin heals. We talked about how the heart heals, and the acute inflammation process, it's neutrophils that provide in the first 24 hours are your inflammatory mediator. So in the margin, hypersegmented polys or hypersegmented neutrophils are seen in folate B12 and folate and B12 deficiency, so that's something worth knowing, and we're going to mention that later. What were your neutrophil chemotactic factors that we talked about when we were discussing leukocyte extravasation? Once leukocytes get into tissues, how do they know where to go? Well, some of the neutrophil chemotactic factors were leukotriene 8, leukotriene B4, interleukin 8, and complement C5a, right? So make sure you know those. We also talked about bar bodies and neutrophils. Is that extra little dumbbell-like lobe of neutrophils, and bar bodies are an inactivated X chromosome, right? So who has bar bodies? Well, you're going to see bar bodies in some of the neutrophils in Klinefelter's patients. Obviously, they have an inactivated X chromosome. But also just females. Females have inactivated X chromosomes. Only one of the two are activated in the cells. Moving on, monocytes and macrophages. So monocytes, they differentiate into macrophages in the tissue. Macrophages can function as antigen processing cells. We talked about different types of phagocytes and different tissues. So what was a phagocyte that we saw in the brain? It was microglia, right? What was a phagocyte that we saw in the liver? Kupffer cells. And what was a phagocyte that's in joints? I mentioned it one time just very briefly. In the joints, your phagocytes are A cells. So something possibly worth knowing. On page 344, your dendritic cells, these are your professional antigen-presenting cells. They're the main inducers of the primary antibody response called the Langerhans cells in the skin. Lymphocytes are you have your B lymphocytes and your T lymphocytes. So those are your lymphocytes. Your B lymphocytes have these surface markers, CD19, CD20, and CD21. And we also have talked about how there's immunoglobulin D and immunoglobulin M on the surface of B lymphocytes. If you look at towards the bottom of that section on B lymphocytes, it says when antigen is encountered, B cells differentiate into plasma cells and produce antibodies. And then also the next saying has memory. So the B lymphocytes create memory B cells when they're exposed to antigens. And that's particularly important because this is the main cell type that is stimulated with vaccines, right? With immunizations, you're stimulating your memory B cells. So that's important to know. Your plasma cells on the next section, So again, the B cells differentiate into plasma cells, which produce large amounts of antibody specific to a particular antigen. What was the particular organelle that is in abundance of in plasma cells? Well, think about it. You're making a lot of protein, and that protein is being secreted outside of the cell. So which organelle do you need to make a whole lot of protein? You need rough endoplasmic reticulum. So you have a whole lot of rough ER in your plasma cells making immunoglobulin for you. And in the disease state, look in the margin there. It says multiple myeloma is a plasma cell neoplasm. And there's a particular subset of multiple myeloma, but for the purposes of step 1, you can think of these terms interchangeably, which is plasmacytoma. So a plasmacytoma, a tumor of a bunch of plasma cells, is multiple myeloma. All right, so think of it that way. And what you have here is you have one particular B cell that's, a whole bunch of them. So a whole bunch of one particular B cell. Each of these B cells or plasma cells are making antibodies, and they're making one particular type of antibody. So these are, monoclonal antibodies, and that's why you see the monoclonal antibody spike. When you encounter an infection, there's lots of different antigens on that infectious organism, and so your body responds by making lots of different antibodies to counteract that infection. Well, with multiple myeloma, it's one particular antibody in excess, and on the light chain, it's either going to be a lambda or a kappa, right? So that ratio of lambda kappa is going to be thrown off balance with multiple myeloma. There's also, with multiple myeloma, something called Russell's bodies, and we're going to talk about multiple myeloma in a little bit, but with multiple myeloma, you have Russell's bodies, which is immunoglobulin accumulation within plasma cells that you see. Moving on, your T lymphocytes, you see that we talked about how all T cells have CD3 on them, your helper T cells have CD4, your cytotoxic T cells have CD8. And so if you don't remember much about T cells, you can go back to the immunology section, but that's all we're going to discuss with T cells there. On page 345 is your blood groups. So definitely important to know your different blood groups, but this is just really basic stuff, right? This is like, high school, life science or high school anatomy and physiology. So just review that blood group section there. I don't think I have anything to add that you probably don't already know. So take a look at that section. And let's move on to something a little bit more complicated, which is the convergence of the coagulation, complement, and kinin pathways on page 345. We're going to start on the left-hand side of this diagram, which is the coagulation cascade. So basically, these are your coagulation factors. Where do your coagulation factors come from? Well, they come from the liver, right? So your liver makes these coagulation factors. When your liver is injured, like with cirrhosis, it does not make coagulation factors. That's why with cirrhosis and end-stage liver disease, your PT and INR are elevated because you do not have the coagulation factors. So you see here on the far left is your extrinsic pathway, using factor 7, and then your intrinsic pathway is using factor 12. And you see also factor 12 is important in the activation of kallikrein, so that's something worth knowing, that the convergence of these pathways uses factor 12. So factor 12A is important for the convergence of the kallikrein pathway and the coagulation pathway. All right, so what else here? You see in your intrinsic pathway you have 12, which is cleaved to 12A, which cleaves 11 to 11A, and then 9 to 9A. And what happens if you're deficient in factor 9? Well, that's hemophilia, right? So hemophilia B is a deficiency of coagulation factor 9. And from factor 9, factor 9A is used to generate factor 10A, and in the process use factor 8A. And so factor 8 is referred to as an accelerating factor. It's an accelerating factor, as is factor 10. Factor 8 and factor 5 are your two accelerating factors. And if you're deficient in factor 8, what disease is that? That's hemophilia A. So the way I remember the difference between hemophilia A and hemophilia B is I just use two words, 8 and benign. All right, so 8, factor A, and or hemophilia A and factor 8, combine the two, and you just get 8 with an A. And benign is hemophilia B and factor 9, B9, benign. So if you can just remember those two words, you can remember which factors are deficient in the different hemophilias. What is the rate limiter of the coagulation cascade? And it's actually this factor 10, the convergence of the extrinsic and the intrinsic coagulation pathways at factor 10 is the rate limiter. We mentioned that factors 8 and factor 5 are your accelerating factors. There are specific substances that inhibit your accelerating factors, factor 8 and factor 5, and those substances are protein C and protein S. All right, so the coagulation cascade is procoagulation. It generates clots, and by inhibiting that with protein C and protein S, you break down clots. Well, guess where protein C and protein S come from? They also come from the liver, and we're going to talk about how Coumadin, let's just talk about it now. Coumadin or warfarin is going to inhibit a lot of the generation of a lot of your coagulation factors, 10972, but also inhibits the production of protein C and protein S. And so by inhibiting your coagulation factors 10972, Coumadin or warfarin inhibits coagulation and reduces clot formation, right? But by inhibiting protein C and protein S, it actually increases clot formation. And unfortunately for Coumadin, it inhibits protein C and protein S more acutely than it does the clotting factors. So therefore, when you give Coumadin, patients actually become hypercoagulable because you are obliterating their protein C and protein S, which normally would inhibit factor 8 and factor 5. So because of that, this is why we combine heparin on the first several days of Coumadin dosing, so that you can overcome that hypercoagulability by using heparin sulfate. All right, so moving on here, you go from factor 10 to factor 2, 2A, and then 2A is involved in breaking down fibrinogen to fibrin monomers, and that the fibrin monomers form the fibrin mesh. So what substance inhibits this thrombin from activating fibrin? What inhibits thrombin from activating fibrin? It is antithrombin. So that's easy enough. Specifically, it's antithrombin 3. So antithrombin 3 inhibits thrombin from activating fibrin. So antithrombin 3, is that procoagulation or anticoagulation? Well, antithrombin 3 is anticoagulation. And so there is a substance that basically increases the effectiveness of antithrombin 3, and that substance is heparin. So this is how heparin works. It works by inhibiting thrombin. Let's see what else. Going from fibrinogen to fibrin, there is another substance that we've discussed a while back that can make this conversion outside of thrombin. So what else converts fibrinogen to fibrin? It is coagulase. So Staph aureus makes coagulase, and it does that. The cross-linking of fibrin is a covalent process, is something that you might want to know. And one other thing here is you see lots of these little asterisks, and on the left you see that all these asterisk steps require calcium and phospholipid. So you don't need to memorize that, but I would know that calcium is essential for the coagulation cascade to be effective. You have to have calcium. So if you put a calcium binder into the system so that there is no calcium, then you're going to decrease coagulation, right? And so one calcium binder that sometimes is used is IV citrate. So citrate is a calcium binder, and it decreases free calcium, thereby decreasing coagulation. So let's talk about heparin and warfarin real quick. On page 362 is where this discussion begins, starting with heparin. So again, it's a cofactor for the activation of antithrombin, decreases thrombin in 10A, has a short half-life, and clinical use for anticoagulation for really anything. So for pulmonary embolism, for stroke, acute coronary syndrome, which is an MI, DVT, used during pregnancy because it is safe in pregnancy. How do we measure the effectiveness of heparin? We use the PTT. Toxicity, of course, it promotes bleeding, so that can be a problem. We've also discussed how long-term use can cause osteoporosis. There's a phenomenon known as heparin-induced thrombocytopenia, which is not a good thing to have. And we're not going to get a whole lot into heparin-induced thrombocytopenia because just knowing it is all you really need to know for step one, that it exists, that heparin can cause thrombocytopenia. So if you have a patient that is on heparin and their platelet count just drops down and they become thrombocytopenic, then that is very, very suspicious for heparin-induced thrombocytopenia. What is your reversal agent for heparin? Is protamine sulfate, but you have to use it very carefully because why are you putting a patient on heparin? To anticoagulate them. So if you put protamine sulfate in there, you're going to bind the heparin and you're going to reverse the anticoagulation, and maybe the thing that maybe they'll form a clot, which is not what you wanted in the first place, right? So be careful with protamine sulfate. Notes, it says the lower molecular weight heparin, known as enoxaparin, you might know it better as Lovenox, is what we're talking about here, acts more on factor 10A, has better bioavailability, sticks around 2 to 4 times longer. So with heparin administration is a constant infusion. It has to be through an IV. In most cases, if you want to ideally anticoagulate somebody. But low molecular weight heparin, or enoxaparin, can just be given sub-Q twice a day, or even once a day in some cases. It depends on what you're trying to do. Are you trying to treat a clot? Then you need to give it twice a day, and heparin needs to be given continuously. If you're trying to prevent clotting, like trying to prevent a DVT, you can use sub-Q heparin 2 to 3 times a day, or you can use enoxaparin once a day to prevent clotting. So preventing clotting is going to be at a lower dose than treating clotting. And you don't need to monitor it, the low molecular weight heparin. It's weight-based dosing that doesn't need to be monitored. And if for some reason you do want to monitor it, you don't use the PTT. What you'd use is an anti-10A activity level. So you look for anti-10A activity. It mentions heparin-induced thrombocytopenia also. So this is where heparin binds the platelets. You have autoantibody production, destroys the platelets, resulting in thrombocytopenia in a hypercoagulable state. So what do you do for heparin-induced thrombocytopenia? And again, remember, you have the patient on heparin for a reason. You want them to be hypocoagulable, but with heparin-induced thrombocytopenia, it's kind of counterintuitive. Even though you're putting on heparin, which normally would make somebody hypocoagulable, and in this case now you're decreasing platelets, you would think that would make somebody even more hypocoagulable. But instead, like it says, it overactivates the remaining platelets and causes a hypercoagulable state. So now you got to do something else, right? Because the patients are no longer hypercoagulable. So what you use is the next 2 drugs, lipirubin or bivalirudin. And so bivalirudin is Angiomax. You might have heard of that one. And so these are high-rudin derivatives. They directly inhibit thrombin. So they're not working on antithrombin to inhibit thrombin. They directly inhibit thrombin. Used as an alternative to heparin for anticoagulating patients with heparin-induced thrombocytopenia. So you have to, these patients that have heparin-induced thrombocytopenia, you have to put them on an anticoagulant because of their now hypercoagulable states. And you do that with one of these 2 drugs. And additionally, you would put them on warfarin as well, because they're going to need to be anticoagulated for an extended period of time because of this, at least a month, or at least until the platelets, or once the platelets get above 100,000, then you definitely need to put them on warfarin. But until that time, they definitely need to be on lipirudin or bivalirudin. There's another drug, which is argatroban, and argatroban is also a direct thrombin inhibitor, but this particular one is not derived from high-rudin. So that is argatroban, one you might want to be familiar with. So let's move on to page 362. I'm going to talk about warfarin or Coumadin. So this interferes with the synthesis and gamma carboxylation, know that term, gamma carboxylation, of vitamin K dependent clotting factors. So this is, you can think of warfarin as anti-vitamin K. The way that you reverse warfarin is to give vitamin K, all right? And so patients that are on warfarin are not supposed to take in, any vegetables or any substances that will elevate vitamin K levels, like leafy greens, for instance. So what are your vitamin K dependent clotting factors? 10, 9, 7, 2. The way I remember that, the way that I can spout these off so quickly, is because I think of, I have a mnemonic. My mnemonic is that disco started in 1972. And so this mnemonic helps me remember that there's a C and an S in the word disco, and warfarin inhibits protein C and protein S. And then 1972, you can use the first 1 as a 10, so 10, 9, 7, 2. So disco started in 1972, and warfarin inhibits those clotting factors, or those components that are stimulated by vitamin K. So this is, it says, in laboratory assay has an effect on the extrinsic pathway and increases your PT. So to monitor warfarin, you use your PT, or more specifically, in order to have stability from lab to lab, you use your INR, which is indirectly a measure of your PT. So there's a mnemonic for this also, which is WEPT. So W-E-P-T, for W is for warfarin, E is for extrinsic pathway, and the P-T is what you monitor for warfarin. So when do we use warfarin? It's used for chronic anticoagulation. Cannot be used in pregnant women because it can cross the placenta, and it is a teratogen. And so if you need anticoagulation in pregnancy, you reach for heparin, or enoxaparin is fine as well. And so further down on page 362, you see the differences between heparin and warfarin. The only one that we haven't mentioned is the treatment of acute overdose. Just to reiterate, for heparin, it's protamine sulfate. And then for warfarin, you give IV vitamin K, or you can give it sub-Q is another way to give it, and fresh frozen plasma. So the IV vitamin K or sub-Q vitamin K is going to allow the liver to generate more clotting factors again, but it's going to take 2 or 3 days for those clotting factors to be made. So in the meantime, if you need those clotting factors immediately, you have to give fresh frozen plasma to get them on board. Vitamin K isn't going to do it immediately, but vitamin K just enables the liver to do that. And then again, just to reiterate, when you start warfarin, protein C and S are the ones that are acutely limited. Therefore, with the initiation of warfarin, you become hypercoagulable. So always when you start warfarin, it needs to be with heparin or enoxaparin to counteract that hypercoagulability. And then once the INR is in the appropriate range, which is usually 2 to 3, then you can stop the heparin or enoxaparin and just continue the warfarin. Okay, so back to page 345. We're done with the left-hand side of this diagram. Let's talk about the right-hand side of this diagram real quick. So procallicrin to callicrin, again, what is the important thing that makes that conversion was factor 12A, right? So 12A is an important thing to know there. And then the callicrin basically takes plasminogen, going to the right there, and it breaks it down into plasmin. And then plasmin is a clot-busting drug, right? So plasmin breaks down clots and breaks down the fibrin mesh. So there are drugs that we've discussed previously. We talked about them in the cardiovascular section that basically facilitates the plasminogen going to plasmin. And those drugs were TPA, streptokinase, and urokinase. And if you want to refresh your memory on those, you can go to page 363 and see that pathway. So those drugs stimulate plasma, which breaks down clots. What else here? So callicrin also takes that to going to the upper right there, HMWK, and generates bradykinin. And HMWK is high molecular weight callicrin. High molecular weight callicrin to bradykinin. And that bradykinin you can think of as kind of like serotonin. It's kind of like histamine. It increases vasodilation, increases permeability, increases pain. So bradykinin, we've talked about, causes the cough. Whenever you give ACE inhibitors, if you give an ACE inhibitor, let's start with this. ACE enzyme, angiotensin converting enzyme, breaks down bradykinin, right? So when you give an ACE inhibitor, you do not break down bradykinin. So when you don't break down bradykinin, you have increased vasodilation, increased permeability, increased pain, causes angioedema, all right? So angioedema is swelling from the lips to the larynx. It is a life-threatening swelling phenomenon that is of genetic origin, but comes about whenever you give a substance like an ACE inhibitor that allows bradykinin to stick around. So think of bradykinin in the same note that you think about heparin, think about bradykinin in the same note that you think about histamine or serotonin. They all kind of do the same type of a thing. All right, so that's pretty much it for those pathways there.
Now let's go to Dr. McGinnis.
So let's turn to page 346 and we'll discuss platelet plug formation and thrombogenesis. So you see here on 346 this diagram where it shows injury, which leads to platelet adhesion, and then all the way over there on the right, platelet activation, and then down below, platelet aggregation. And it's important to understand each of these steps, and we're going to talk about each of these in some detail on the next page. But note there at the bottom, the whole purpose of platelet aggregation is it creates a temporary plug that stops bleeding. And so we'll see how that works. So let's look at page 347 and the diagram of thrombogenesis, but also get out your study guide and look at page 1, under hematology, page 1, question 9 and question 10. And We're going to go over those kind of side by side, so that you can lay those two pages side by side with first aid, and that'll be helpful. So thrombogenesis is the formation of an insoluble fibrin mesh, and as you look at this diagram, there's a lot of arrows, there's a lot of little tiny print, so let's kind of talk about each of these pieces. First of all, what's inside an endothelial cell? Down at the bottom right, inside the endothelial cells we have von Willebrand's factor, and also thromboplastin and TPA and PGI2, but I want you to focus on von Willebrand's factor. So look at your study guide number 10. Von Willebrand's factor is made up of several subunits that are linked by disulfide bonds, and they're synthesized, von Willebrand's factor is synthesized by endothelial cells and also by megakaryocytes. So megakaryocytes are what make platelets, so platelets also have von Willebrand's factor in them, as we'll see. The major functions of von Willebrand's factor, there are two major functions. First of all, it complexes with and stabilizes factor VIII. So a von Willebrand's factor deficiency is going to lead to an increase in PTT, so just like you see in hemophilia A. And then the other major function of von Willebrand's factor is it's involved in platelet adhesion to the vessel wall and to other platelets. So a deficiency in von Willebrand's factor will also lead to an increase in bleeding time. So von Willebrand's factor is important for the coagulation cascade and also for platelet aggregation. So let's look back at page 347 and look at what's inside the platelets. So these big circular things are the platelets, and on the upper one you can see that inside the platelets is von Willebrand's factor, as we mentioned, and also fibrinogen, and you have cyclooxygenase and thromboxane A2, and there's lots of other chemicals not listed here that are in platelets. ADP, platelet-derived growth factor, calcium. We'll get to a list of those in just a moment. So there's lots and lots of things inside platelets. So the initiating cause of platelet aggregation is endothelial injury. So you get some type of injury, and that leads to platelet adhesion, activation, and aggregation. So we'll start with adhesion. So you get this injury and you get exposed collagen. So you can see there at the bottom of the diagram on 347, you see these little triangles. Those are supposed to represent collagen. And the endothelial cell has been damaged, it is ruptured, the von Willebrand's factor has leaked out of the damaged endothelial cell, and the von Willebrand's factor is going to bind to that collagen, and then it's going to also bind to glycoprotein 1b on the platelet, as you see there. So that is how platelets begin to adhere to the damaged endothelium. The injury leads to platelet adhesion. Then you get platelet activation. So platelet activation basically means that the platelets start to release lots of their platelet contents. So let's look again at the study guide on page 1, number 9. You have adhesion and then activation. So the activated platelets start to secrete a bunch of stuff. They secrete ADP, platelet-derived growth factor, serotonin, fibrinogen, lysosomal enzymes, thromboxane A2, which, as you remember, is a prothrombotic substance. It's going to induce thrombosis. Platelets also secrete calcium, which is needed to activate the coagulation cascade. And the platelets secrete thrombin. Now, thrombin converts fibrinogen to fibrin, and fibrin is what forms blood clots. And then also thromboxane A2 is released from these platelets, as we mentioned, and that leads to vasoconstriction and platelet aggregation. So thromboxane A2 comes from platelets and it induces platelet aggregation. So we had adhesion of platelets, then activation of platelets, and now aggregation of platelets. So again, on 347, you see that ADP is released from the platelets, as we mentioned, and it binds to the ADP receptor there on the lower platelet. And when it binds to the ADP receptor, it triggers the expression of glycoprotein 2b3a to come from inside the platelet to outside the platelet. And as you see there, between the two platelets, there's this bridge, if you will, of glycoprotein 2b3a binding to fibrinogen and then binding to another glycoprotein 2b3a molecule on the other platelet. So you get this cross-linking, if you will, and this bridging of all these platelets, and this is the platelet aggregation. They start to aggregate and form a little plug to temporarily stop the bleeding, as we mentioned. So if you look there in the margin on 347, you see where all of these different drugs act in this process. So the first one there is aspirin, which inhibits cyclooxygenase. Remember, cyclooxygenase is the enzyme that's going to convert arachidonic acid into thromboxane A2. And so if you inhibit cyclooxygenase, you're inhibiting the production of thromboxane A2, which inhibits further platelet aggregation. So aspirin is going to inhibit platelet aggregation. The next drugs are ticlopidine and clopidogrel. These both inhibit ADP-induced expression of glycoprotein 2B3A. So again, you see that it says there that the ADP receptor is irreversibly blocked by clopidogrel and ticlopidine. So these drugs will also inhibit platelet aggregation. And then finally, it says abciximab inhibits 2B3A directly. So abciximab was mentioned in the cardiovascular section as a 2B3A inhibitor. There's also other similar drugs, tirofiban and eptifibatide. Both of these, or all three of these drugs, can be used either during myocardial infarction or after an angioplasty and stenting to inhibit 2B3A and inhibit platelet aggregation. So now take a look at your study guide on page 1 and look at questions 1 through 8. And go ahead and pause the video and answer those questions, and then Dr. Jenkins will come back and review those answers with you.
So let's go ahead and go through these answers. So number 1 on page 1, what allows red blood cells to change shape as they pass through vessels? That was spectrin, right? Number 2, what are some of the different causes of polycythemia? So the first thing to think about is elevated erythropoietin. So renal cell carcinoma, hepatocellular carcinoma, pheochromocytoma, hemangioblastoma all can cause polycythemia. Chronic hypoxia because of pulmonary disease like with COPD or maybe obstructive sleep apnea can cause polycythemia. Polycythemia vera can cause polycythemia. And we also mentioned that 65% of Down's patients at birth have polycythemia. Of course, that is just a short list. There's lots of things that can cause polycythemia, but those are some of the things we've mentioned throughout the course. Number 3, what coagulation factor is deficient in hemophilia A? It's factor 8, A8. In hemophilia B, it's factor 9, B9. Clotting factors require vitamin K for synthesis, 10972, and protein C and protein S. So DISCO started in 1972. That's your mnemonic for that one. What are the treatments for overdose of heparin and warfarin? So for heparin, it's protamine sulfate. For warfarin, it's fresh frozen plasma and vitamin K. Lab value for monitoring heparin is your PTT. For warfarin is your PT, but more appropriately your INR. And typically, we want to keep the INR between 2 and 3 for most diseases where you're requiring warfarin. INR of 2 to 3 is pretty standard. Some rare cases, the INR needs to be like 2.5 to 3.5, or sometimes 1.5 to 2.5, depending on the disease. But in general, think 2 to 3. And in enoxaparin, you use factor 10A activity. And number 8, what is the treatment for heparin-induced thrombocytopenia? We said that you have to anticoagulate these patients because they are now hypercoagulable, and you do that with lipirudin or bivalirudin, are 2 drugs that you can use. Okay, let's move on to pathology on page 348, pathologic red blood cell forms. This is a great little section. They've done a great job this year by putting these little illustrations in here. There's at least 3 high-yield pathologic red blood cell forms, and I don't think it's fair to tell you exactly which 3 that they are, but this section is, a 4-star section. It would be very surprised if you didn't have to know at least one of these different pathologic red blood cell forms. So let's go through these. Acanthocytes, these are your spur cells, and what you see with acanthocytes is they are irregularly spiked red blood cells. So they're spiked in a random, irregular type of a pattern. Just FYI, this is really not that important, but technically there's something called a Burr cell that's different than a spur cell, and a Burr cell is a regularly spiked red blood cell. And so with your acanthocytes or spur cells, these are seen in liver disease and A-beta lipoproteinemia. And if you don't remember what A-beta lipoproteinemia is, it's mentioned also on page 115 of First Aid, so you can look there. Basophilic stippling, the main thing to know with basophilic stippling, the thing that I really want you to tie together with basophilic stippling is lead poisoning. So tail is a decent mnemonic. These things can cause basophilic stippling, thalassemias, anemia of chronic disease, iron deficiency, but mainly think about lead poisoning as a cause of basophilic stippling. What is it? It's, you're inhibiting the enzyme that breaks down RNA, and so you have denatured RNA within the red blood cell, is what you're looking at here. Bite cells are seen with G6PD deficiency. What causes bite cells? These are macrophages that just take a chomp out of these red blood cells as they go through the spleen. Elliptocytes with hereditary elliptocytosis, that's not too difficult. Macro ovulocytes is seen with megaloblastic anemia and marrow failure. Ring sideroblasts with sideroblastic anemia. Your schistocytes, these are fragmented red blood cells. And what's going on here, it's not macrophages that cause this pathology. It's red blood cells that get forced through areas that cause damage to them. So imagine a big fibrin network, a fibrin strand network, and red blood cells being forced through that. And basically, it's kind of like, slicing meat at the deli. There's just a thin slice gets taken out of these red blood cells as they pass through. So it's a fragmented red blood cell. So when do you have, fibrin all over the place that can slice up these red blood cells? Well, DIC, fibrin around traumatic hemolysis, And then TTP-HUS is another scenario where you see schistocytes. Sickle cells, you guys know what that one is. Spherocytes, where red blood cells lose their biconcave shape. They become more spherular. Hereditary spherocytosis is the classic time where you have these spherocytes. Teardrop cells, seen with myelofibrosis. Target cells, the mnemonic that they give you is HALT. I like the mnemonic THAL. Same letters, just rearranging them to THAL to help you remember that thalassemia is one of them, but also hemoglobin C disease, asplenia, and liver disease. So you see with liver disease, you can have target cells, and then back all the way up to the top of the page with liver disease, you could have acanthocytes. So there's some crossover with some of these. On page 349. Other ones, Heinz bodies, definitely need to know about. So oxidation of iron from ferrous to ferric, which is the F3 iron, leads to denatured hemoglobin precipitation and damage to the red blood cell membrane, leads to formation of bite cells. So when do you have this oxidation? Whenever you take an oxidizing agent in a patient with G6PD deficiency. So patients with G6PD deficiency cannot go through their H&P shunt, so they cannot generate reduced glutathione, which is technically an antioxidant within the cell. So these G6PD deficient patients are sensitive to oxidative damage, and you will have Heinz bodies and bite cells also. So Heinz bodies and bite cells with G6PD deficiency. Howell-Jolly bodies are basophilic nuclear remnants found within red blood cells seen in patients with a functional hyposplenia or asplenia. So who does not have a spleen? Patients that have had splenic trauma and had their spleen removed. Patients with sickle cell who have had an autosplenectomy, autoinfarction of the spleen. Or maybe patients with ITP, idiopathic thrombocytopenic purpura, who have had their spleen removed to treat that disease, will then have Howell-Jolly bodies, which again are nuclear remnants found within red blood cells. So let's go ahead and take a look at page 1 of your handout, question number 11. What pathologic form of red blood cell would you see in the following diseases? Just to do a brief recap, make sure you got this. Answer question number 11, then we're going to go through that answer together. So let's go through these answers. The first one, with lead poisoning, you see basophilic stippling. With G6PD deficiency, you might see bite cells and also Heinz bodies in your red blood cells. With DIC, you're going to see schistocytes. With A-beta lipoproteinemia, you're going to see acanthocytes, which are spur cells. And with asplenia, you might see Howell-Jolly bodies. So, definitely ones to be aware of. Not the only ones that are high yield, but definitely ones to be aware of. So go ahead and take a look at question number 13, what are the different forms of hemoglobin. Before we talk about anemia, let's cover the different types of hemoglobin. Hemoglobin is found within red blood cells, and that's what binds the oxygen and allows red blood cells to carry oxygen is a hemoglobin. And so hemoglobin A, what is hemoglobin A? It's 90% of your normal hemoglobin. It's hemoglobin is 4 subunits. So hemoglobin A is 2 alpha, 2 beta subunits. Hemoglobin A2 is also considered normal. 2% of our hemoglobin in a normal individual is hemoglobin A2. It's 2 alpha, 2 delta subunits. Hemoglobin A1C is hemoglobin in poorly controlled diabetes. This is a hemoglobin that has glucose bound to it. It is normal hemoglobin A, but it's hemoglobin A1C, so it has glucose bound to it. How does glucose get on this hemoglobin? By non-enzymatic glycosylation. There's no enzyme that does this. It just sort of happens. Hemoglobin F is your fetal hemoglobin, 2-alpha, 2-gamma. The gamma chains replace the beta chains. Hemoglobin Gower is an embryonic type of a hemoglobin. Even before hemoglobin takes place, this is more like your yolk sac hemoglobin. Hemoglobin S is sickle cell hemoglobin. And so with this one, your glutamate is replaced by valine on the beta chain. And then with hemoglobin C, kind of similar to sickle cell, you replace glutamate with lysine on your beta chain. We'll talk about how each of these plays into sickle cell disease and hemoglobin C disease in a little bit. Hemoglobin BART is seen with severe alpha thalassemia. Basically, you have no alpha chains, so what are you left with is, in the fetus, you're left with just gamma chains, right? So, hemoglobin is 4 subunits coming together, so this is 4 gamma chains. There's no alpha chains. It's not compatible with life, so this is, with BART's, hemoglobin BART, it's only a fetal type of a hemoglobin. And then hemoglobin H, it's 4 beta chains. Again, there's no alpha chains here. All right, so let's talk about anemia next on page 349. Starting with microcytic hypochromic anemia. So anemia is definitely high yield for step 1. And again, it's not difficult stuff, right? It's softball type of stuff that you need to know with anemia. So iron deficiency anemia, of course, the most common cause of iron deficiency anemia is, either poor iron intake or in the U.S., more commonly we see blood loss causing iron deficiency anemia, either through menstruation or through colon cancer and occult bleeding of colon cancers. And so chronic bleeding, malnutrition, increased demand, so pregnancy, you might have an iron deficiency anemia. However, you do have a physiologic anemia of pregnancy because your plasma is increasing at a greater rate than your red blood cells. What else? May manifest as Plummer-Vinson syndrome. We have a triad of iron deficiency anemia, esophageal webs, and atrophic glossitis. One thing that you definitely need to be aware of is if you have a patient over age 40 with iron deficiency anemia with no easily identifiable cause, they need to be ruled out for colon cancer. They need a colonoscopy. Definitely over age 50, and most physicians would also say even after age 40. And if you have a woman over age 35 that has a new metrorrhagia or menorrhagia or menometrorrhagia and has increased uterine bleeding after age 35 and has an iron deficiency as a result of that, they might have endometrial hyperplasia or endometrial carcinoma, so they need to be ruled out for that as well. Let's look at image page 5. And while we're on image page 5, let's just take a look at all these different anemia pathologies on image page 5. Image 22 is the first one we're going to look at, which is, with iron deficiency anemia, you have small red blood cells. Compare the red blood cell size to the neutrophil there, and you can see that they are small. And, the pallor, the central pallor of these red blood cells is exaggerated, and so that's, hypochromic. If you look to the left there, you see a thalassemia major. You have target cells there, so the central pallor is, you have kind of a hyperdensity in the sensor. So it's on image page 21. You also see target cells on the image page 20A and image page 20B, so classic target appearance. So again, thal is your mnemonic for your target cells for thalassemia, hemoglobin C disease, asplenia, and liver disease all can create target cells. And then the bottom of page 5, image 23A, you have sickle cell anemia and what sickle cells look like. And on the right, image 23B, you have a splenic infarction of sickle cell anemia. We're going to talk about sickle cell in a little bit, but while we're on this page, you can see it there. And characteristically, this is an infarction that's causing that change in density in the spleen because it's a wedge-shaped lesion. When you perfuse an organ, it's perfused from centrally to peripherally, and as it goes out peripherally, you're expanding your blood supply in a wedge-shaped fashion. So that's a vascular defect there because of that wedge shape of the lesion. Okay, let's go back to page 349. Talk about some other causes of microcytic hypochromic anemia. There's alpha thalassemia. where the defect is in the alpha globulin chain, decreased alpha globulin synthesis, and there's different degrees of alpha thalassemia. So take a look at this slide here. You can be deficient in one alpha gene. I mean, basically, for on each chromosome, you have two different two different genes coding for your alpha chains. And so you might just be deficient on one of those genes on one of those chromosomes, and that's not going to cause any problems. If you're deficient in two of those genes, either a hit on one entire chromosome or one of those genes is affected on either chromosome, then that's going to be alpha thal trait. And in general, that's not associated with any problems either. But when you hit three of those genes and you're left with just one gene left, that's hemoglobin H disease. And in the last row, you see if you're deficient in all of these genes, then that causes hydrops fatalis. So looking back into your book, it says deletion of 4 genes is incompatible with life. You have hemoglobin Bart's, which is your 4 gamma chains, which causes hydrops fatalis. What is hydrops fatalis? It's a generalized edema of the fetus that causes death. Deletion of 3 genes, you have hemoglobin H disease, which is 4 Bart's, 4 beta hemoglobin, 4 beta globin molecules to make your hemoglobin. And deletion of 1 or 2, again, does not really cause many problems. So your beta thalassemia is the next disease. So if you look at this slide, on each of your chromosomes, you have only one gene or one allele coding for your beta chain. So beta thal minor is either a deficiency that's of one of those beta chains, that's the beta minus that you see there, or an abnormally shaped or an abnormal function of your beta chain that's not functional. So that causes beta thal minor. And then beta thal major is both of these genes are either deficient or non-functional, misfolded in a way. So looking at your book, it says beta thal minor, you're a heterozygote. The beta chain is underproduced, usually asymptomatic, diagnosed, confirmed by hemoglobin A2 in excess of 3.5%. So we said that hemoglobin A2 is normally, about 2%. So in beta thal minor, you can have excess production of that. With beta thal major, the beta chain is totally absent. So you have severe anemia requiring blood transfusion, and that can cause hemochromatosis with repeated transfusions. How would you counteract that hemochromatosis? Well, you're not going to do phlebotomy, right? You're not going to remove red blood cells because you're trying to add red blood cells. So deferoxamine is the drug that you would use here for hemochromatosis. With beta thal major, you would see marrow expansion, a crew cut appearance on the skull X-ray. More descriptive would be marrow hyperplasia. And with marrow hyperplasia, you have marrow being made in your skull, and that says, increase, and that creates this crew cut appearance on the skull X-ray. Skeletal deformities also result in chipmunk faces, and both major and minor you have increase in your hemoglobin F, which just makes sense. If you have no beta chains, how else are you going to make hemoglobin? Well, you use your hemoglobin F, alpha 2, gamma 2. And there's also a hemoglobin S, beta thal heterozygote. We have a mild to moderate sickle cell disease, depending on the amount of beta globin underproduced. So, that's problematic also. So, lead poisoning is the next cause listed of microcytic hypochromic anemia. We've already seen that you can have basophilic stippling. Let's go ahead a few pages to page 354. And in this chart on page 354, you see the section on lead poisoning. You see the enzyme that you affect is ferrochelatase and ALA dehydratase. And so basically, these enzymes are important in the production of heme, which you see at the bottom of the page. We're going to come back to this page in a little bit. Right now, we're just talking about lead poisoning. And presenting symptoms with lead poisoning, you get a microcytic anemia, GI and kidney disease. Children have exposure to lead paint and mental deterioration. When is lead paint problematic? At what year did they stop putting lead in paint? Well, it's 1978. After 1978, you're safe, all right? And before 1978, you may have had lead in paint. So if you live in an old house, you're going to want to know, when it was painted and if there's any potential that there might be lead paint around, because kids like to pick it up and eat it, and it's not good to do that. Of course, that can cause mental retardation, mental deterioration. Adults, when are they going to expose to lead? Would be environmental exposure, would be battery ammunition or radiator factories. It's going to cause headache, memory loss, and demyelination. Turn to page 350. You see a section on lead poisoning there. You have your lead lines on the gingiva. These are called Burton's lines, so just a darkening of the gingival lines. You might have, especially in growing children's, lead lines on the epiphysis of long bones on x-ray, so where the bone is growing, just a big, just like a metal-looking line, a metal-looking plate on the bone. It's, denser than bone, so it's very obvious to see that. Encephalopathy and erythrocyte basophilic stippling, abdominal colic and sideroblastic anemia, and then drops. It's a neurologic problem, so you can have wrist drop and foot drop. How to treat it? For adults, you can use dimercaprol or EDTA. For kids, use Suxamer. All right. So that's lead poisoning. Going back to page 349. The next anemia is sideroblastic anemia. It's a defect of heme synthesis. And again, you get your ringed sideroblasts, which we saw back on page 348. How do we treat it? Is B6 supplementation. Reversible causes of this include alcohol and lead. And with sideroblastic anemia, you have elevated iron level, normal TIBC, which is total iron binding capacity, and increased ferritin also.
Now let's go to Dr. McGinnis.
Okay, so let's turn to page 353, and we'll discuss the lab findings associated with different types of anemia. So the first one there is iron deficiency, and let's contrast for a moment. Let's look at both iron deficiency and anemia of chronic disease. Anemia of chronic disease is generally considered to be a normocytic anemia, but it can be microcytic, so you need to be aware of how to differentiate anemia of chronic disease from iron deficiency anemia, which is by far the more common type of microcytic anemia. So serum iron is going to be low in both of these. Transferrin, or TIBC, which indirectly measures transferrin, is going to be elevated in iron deficiency, and it's going to be low in anemia of chronic disease. So transferrin transports iron in the blood. That's its function. What's the relationship between TIBC and transferrin? Basically, TIBC, or total iron binding capacity, is equal to transferrin times 1.4. So anything that elevates transferrin is going to elevate TIBC. So TIBC is elevated in iron deficiency, and it's decreased in anemia of chronic disease. The idea is, if you're iron deficient, your body's trying to get iron anywhere. It wants to transport iron from storage to the cells where it can be used. So in iron deficiency, where there's no iron, your body's going to have lots of transferrin, and TIBC is going to be elevated. In chronic disease, although the serum iron is low, that's not the main problem in anemia of chronic disease, so transferrin will be low. For ferritin, you see that in iron deficiency, ferritin is low. Ferritin is your stored iron, and ferritin is found in cells. Iron is stored inside cells. So you're iron deficient. You've used up all your iron stores, so ferritin is going to be very low in iron deficiency anemia. In anemia of chronic disease, ferritin will generally be elevated. Ferritin is an acute phase reactant. It's going to be elevated in any type of inflammatory process, infections, and it can be elevated in cancer and lots of other things. So ferritin can be elevated for a lot of different reasons, and one of those reasons is anemia of chronic disease. You can also kind of hang your hat on making the differentiation between anemia of chronic disease and iron deficiency anemia based on the percent transferrin saturation, or that's the ratio of serum iron to TIBC, and that'll generally be calculated for you when you order iron studies. In iron deficiency, the transferrin saturation is going to be markedly decreased because you've got a lot of transferrin out there, but you don't have much iron, so the ratio is going to be very, very, very low, usually less than 12%. Transferrin saturation is expressed in a percentage, so very low, less than 12% for iron deficiency. For anemia of chronic disease, it's generally going to be higher than that, and it's going to be in the normal range. Now, the normal range for transferrin saturation is anywhere from about 12 to 45 or 50, so it's a broad range. Generally, in anemia of chronic disease, you're going to have a transferrin saturation greater than 18%. So there is a small window there where it might be difficult to tell if it's 15 or 16. You have to kind of scratch your head and you don't really know. It could be anemia of chronic disease, but more often with anemia of chronic disease, transferrin saturation is going to be higher than that. It's going to be higher than 18%. So let's look next at hemochromatosis. In hemochromatosis, serum iron is elevated. This is a disease where you have a lot of iron stored up. You have too much iron in the body. So serum iron is going to be elevated. Transferrin is going to be low. Transferrin is basically saturated. There's too much iron, so your body's not making a lot more transferrin. Ferritin is going to be elevated. So if you have normal ferritin, you can probably rule out hemochromatosis. If you have elevated ferritin, that doesn't prove that you have hemochromatosis. As I said, ferritin can be elevated for a lot of different reasons. It's an acute phase reactant. So elevated ferritin doesn't prove hemochromatosis, but normal ferritin pretty much rules out hemochromatosis. And then the transferrin saturation is going to be very high. Again, you have lots of iron. All the transferrin is saturated, so transferrin saturation very high and hemochromatosis. The next column, pregnancy and oral contraceptive use. You're going to have increased transferrin. That's a result of estrogen. So you have increased transferrin, and you're going to have decreased transferrin saturation. So the last column is lead poisoning. Lead poisoning is pretty rare, and it's a rare cause of anemia. Basically, the reason lead poisoning causes anemia is because it impairs the body's ability to manufacture heme. So you can reason out what the iron numbers are going to do based on that. So iron is going to be elevated because your body's not using iron to make heme, so you got a lot of extra iron lying around. When iron is elevated, all that iron is going to be bound to transferrin in the serum, so your transferrin saturation is going to be elevated. The overall transferrin, or TIBC, is going to be decreased. So let's turn things back over to Dr. Jenkins to continue our discussion of anemia.
So let's move on to macrocytic anemia on page 350. And macrocytic anemia fundamentally is due to impaired DNA synthesis, like it says, and as a consequence, it takes a long time for the red blood cell to mature, and the cytoplasm expands and makes larger red blood cells in the process. And if you see macrocytic, commonly we think about megaloblastic anemia as the prototypical macrocytic anemia. And if you see megaloblastic anemia or macrocytic, the first thing to think about is B12 and folate deficiency. Because remember, what's the most common vitamin deficiency in the U.S.? It's folate deficiency, right? So let's talk about these two things. So megaloblastic anemia due to folate deficiency, you have hypersegmented neutrophils, which you also have in B12 deficiency. You can have glossitis. We said lots of B vitamin deficiencies result in glossitis, and so you see that with both of these. Decreased folate with folate deficiency, decreased B12 with B12 deficiency, and in both of them, homocysteine will be elevated. However, with the folate deficiency, methylmalonic acid will be normal, and with B12 deficiency, methylmalonic acid will be increased. But fundamentally, how do you determine which is which? You have a patient with megaloblastic anemia. You suspect either folate or B12. You just check a folate or B12 level. That's what you do clinically. So the etiologies of folate deficiency is definitely malnutrition. Alcoholics are a common scenario. You just don't get enough nutrition, not enough fruits and vegetables. Malabsorption, impaired metabolism. So certain drugs like methotrexate and trimethoprim interfere with folate metabolism. Or if you have a higher requirement like a hemolytic anemia or pregnancy, that might cause a folate deficiency. With B12 deficiency, what causes that? Again, malnutrition, alcoholics, malabsorption with Crohn's disease. And as far as malnutrition, we also said that B12 is a very critical nutrient to supplement in vegetarians. So that's something to be aware of. And the Diphyllobothrum latum is the fish tapeworm, can cause B12 deficiency. And the other huge clinical clue for B12 deficiency on your question stem is the neurologic defects, the subacute combined degeneration or the peripheral neuropathy that might result from a B12 deficiency. We also talked about a megaloblastic anemia that was not correctable by B12 or folate. We talked about it back in the biochemistry section. It was back on page 68, and that was caused by orotic aciduria. A biochemical deficiency called orotic aciduria can cause a megaloblastic anemia not correctable by B12 or folate. So something to remember there. What are your other causes of macrocytic anemias where you don't have hypersegmented neutrophils like you do with B12 and folate? Liver disease, alcoholism due to the bone marrow suppression, even though there may not be B12 or folate deficiency. Reticulocytosis, metabolic disorders like orotic aciduria we mentioned, and certain drugs like 5-fluorouracil is a anti-cancer metabolite. AZT is zidovudine, and hydroxyurea also. So a lot of your cancer drugs are going to cause myelosuppression because they're inhibiting rapidly growing cells, which is why a lot of cancer patients, while they're on cancer drugs, need to be put on something like erythropoietin, right? Okay, moving on, normocytic normochromic anemia. Intravascular hemolysis. So what causes intravascular hemolysis to cause a normocytic normochromic anemia? Well, paroxysmal nocturnal hemoglobinuria. We've talked about that one before back in the immunology section. We said it's a deficiency of CD55 and CD59. So you have complement-mediated attack of your red blood cells. An autoimmune hemolytic anemia can cause intravascular hemolysis. We're going to address this one again in a little bit. Mechanical destruction also can cause intravascular hemolysis. So if you have aortic stenosis and a lot of turbulence that results from that, prostatic valves, are going to crush some of your red blood cells. And then extravascular hemolysis, like with hereditary spherocytosis, can cause a normocytic normochromic anemia. G6PD deficiency, you're sensitive to oxidative damage, so you take in something that causes oxidative damage. Pyruvate kinase deficiency is going to cause hemolysis because red blood cells can't generate energy because they can't go through glycolysis. Sickle cell anemia, hemoglobin C disease, and again, autoimmune comes into play here, but this is warm agglutinins. So let's talk about non-hemolytic normocytic anemia. So the normocytic anemia could be due to anemia of chronic disease. And we mentioned anemia of chronic disease earlier with microcytic because anemia of chronic disease commonly causes normocytic but may also cause microcytic anemia. And again, we've looked at this profile before: low iron, low TIBC, high ferritin concentrations. Moving on to aplastic anemia. This is a very unique one. So here you have anemia, neutropenia, and thrombocytopenia. So when you have all three of these lines deficient, this is called a pancytopenia, right? So aplastic anemia, you're not making any of those cell lines. And you definitely need to know the histology of this. You have hypocellular bone marrow with fatty infiltration. So if on your test you see bone marrow and it's filled with adipocytes, you know that you're dealing with aplastic anemia. All right, what causes aplastic anemia? The main thing to know is radiation causes aplastic anemia. So cancer drugs that receive radiotherapy can get aplastic anemia. Drugs can cause it also. They list a few. The chloramphenicol we mentioned causes a gray baby syndrome. Alkylating agents, of course, are anti-cancer drugs. Antimetabolites are anti-cancer drugs. Viral agents like parvo B19, Epstein-Barr virus, HIV, all are associated with aplastic anemia, particularly in sickle cell patients. They're particularly sensitive to some of these viral agents. Fanconi's anemia, we talked about Fanconi's syndrome earlier. Fanconi's syndrome was a proximal tubule reabsorption defect in the kidneys. Well, Fanconi's anemia is different. It's a non-hemolytic normocytic anemia. Here you have it's an inherited defect of DNA repair. And then idiopathic, may follow acute hepatitis also. Symptoms, so fatigue, malaise, and pallor. What's causing that symptom? Well, that's the anemia, right? Purpura, mucosal bleeding. Petechia, what's causing that is the thrombocytopenia, and what's causing the infection as another symptom is the leukopenia. So you can see how these different cell lines are going to cause slightly different clinical presentations. How do we treat it? Withdrawal from the offending agent, of course, immunosuppressive regimens. The treatment is not so important for you guys here, but if you're not making bone marrow, then you can give one of your granulocyte macrophage colony stimulating factors like GCSF or GM-CSF to help make more bone marrow. Kidney disease results in decreased erythropoietin causing decreased hematopoiesis. So we've talked about that one before too. So all you really need to know here, you don't need to have these categories memorized of these different types of anemia. You just need to know specific key things to find with each of these causes of anemia where, the finding would have to be in the question stem somewhere. Like if in the question stem it said, anemia and the marrow was filled with adipocytes, and that would be aplastic anemia. If the question stem said anemia with hypersegmented neutrophils and neurologic symptoms, it's B12 deficiency. All right, so you just need to have certain key points tagged in your mind to each of these specific causes of anemia. All right, let's go to page 352. Talk about your intrinsic hemolytic normocytic anemia. So anemia because of hemolysis within blood vessels. Hereditary spherocytosis is one cause, and defect in proteins that interact with the red blood cell membrane, skeleton in the plasma membrane. So ankyrin, band 4.1, and spectrin. So spectrin, we said, causes the red blood cells to be able to change shape slightly and causes the biconcavity. And so if you're deficient in these things, you get the hereditary spherocytosis. Your red blood cells are spherocytes, and they get clogged up, and that's problematic. So what you have here is less membrane causes small, round red blood cells, no central pallor is how you can identify this. Increased MCHC, mean cell hemoglobin concentration. Think about that. If you have a sphere versus a biconcave disc, which of those cell types do you think you could fit more hemoglobin into? Well, as far as packing volume into a container, a sphere is going to be more efficient than a biconcave disc, so that you can fit more hemoglobin into a sphere. Thus, the increased mean cell hemoglobin concentration. The RGW is increased also. So it's a red cell distribution width. So some of your red blood cells are smaller size, some of them are larger size. And the reason why this causes anemia, like it says there, is the spleen recognizes these abnormal red blood cells and then takes them out. And so the findings here, you're going to have splenomegaly, aplastic crisis associated with parvo B19 infection, Howell-Jolly bodies we talked about earlier. Positive osmotic fragility test is how you diagnose this, and that's something to definitely know. And basically you have a high percentage of lysis of red blood cells at a given concentration of sodium chloride. So red blood cells that would not normally lyse at a given sodium chloride concentration because of the intact structural framework of the biconcave disc, those cells do lyse with hereditary spherocytosis because you do not have that intact structural framework to keep the red blood cell intact. Moving on, G6PD deficiency, we've mentioned that one before. You're sensitive to oxidative stress, at least some of the agents associated with that. Pyruvate kinase deficiency, you can't generate energy. Sickle cell, let's spend a little bit of time on this one. We saw the images in the image page section earlier. We talked about what a sickle cell looks like. We also saw a splenic infarction associated with sickle cell. So 8% of African Americans carry the hemoglobin S trait. So have sickle cell trait, but not sickle cell disease. 0.2% have the disease. And of course, this is very common mutation because of its protection against malaria. Crescent shells, crew cut on the skull from marrow expansion, increased erythropoiesis, also seen in the thalassemia, as we talked about that earlier. Newborns are initially asymptomatic because they have more hemoglobin F, but as they get older, and that hemoglobin F is replaced with hemoglobin A that's problematic, then with hemoglobin S, then they're going to have a problem. Mutation. The hemoglobin S mutation is a single amino acid replacement of the beta chain substitution glutamic acid or glutamate with valine. We talked about that earlier. Pathogenesis. Deoxidized hemoglobin S polymerizes. You have low oxygen or dehydration precipitates sickling. So, you want to warn sickle cell patients not to go up to high altitudes where there's low oxygen concentrations. That could be problematic, and very fundamental to the treatment is to maintain adequate hydration to prevent sickling from taking place. Heterozygotes have malaria resistance complications. Aplastic crisis due to parvo B19. We mentioned that one a second ago. Autosplenectomy. So, of course, with that, you're going to have elevated risk of encapsulated organisms. So they need to be immunized against encapsulated organisms like meningococcal meningitis. They need to be immunized against that. And strep pneumo, they need to be immunized against that. And it's just a good idea to give them a flu vaccine every year as well. Salmonella osteomyelitis is more common in sickle cell patients. Painful crisis is a vaso-occlusive disease, and whenever you occlude something, it becomes very painful because it becomes ischemic. Renal papillary necrosis due to low oxygen. We said that the papillary region of the kidneys is more sensitive to this hypoxia. And splenic sequestration, we saw that image earlier. How do we treat it? Hydroxyurea is going to increase your hemoglobin F concentration, and then ultimately and definitively bone marrow transplantation is what you would need. Hemoglobin C disease, you have a different beta chain mutation. We talked about that earlier. And if they just have one of those, if they're heterozygotes, then it's not going to be much of a problem. If they have one sickle cell mutation and one hemoglobin C mutation, that's pretty bad too, but it's still not as bad as the homozygote for sickle cell disease. And then paroxysmal nocturnal hemoglobinuria, we've talked about that one in the immunology section, and I briefly covered that one a second ago.